Welcome, Dr. Nathan. It's a pleasure to have you with Lyme Disease UK today.
Oh, thank you for having me.
It's our pleasure. So, for anyone that doesn't know Dr. Nathan is a board certified family physician and also a founding diplomat of the American Board of Integrative and Holistic Medicine. His practice evolved into complex medical problem solving, working with patients who had no clear diagnosis from conventional medicine and were suffering with persistent and debilitating illnesses. These included fibromyalgia, chronic fatigue syndrome, chronic Lyme disease with its co-infections, mold toxicity, autism, and all varieties of chronic pain. Dr. Nathan has a special interest in mold and mycotoxins and is the author of several books. He currently practices at Redwood Valley Clinic in North California. So, welcome, Dr. Nathan. If it's all right with you, we'll get going straight away.
That would be great.
Thank you. So, I guess a good place to start really is you've throughout your career practiced in a few different areas of medicine. What drew you to complex cases and people who couldn't get to the bottom of their issues, such as people with Lyme disease and co-infections?
Well, actually, there's a fairly logical progression. Um, I began as a family physician I delivered babies, did a little bit of surgery, worked in the emergency room, and had a very full practice of families. And I, I'm a little bit strange in that I've never been satisfied with telling people I don't know when they presented with something complex or difficult. And I've always been interested in that. I have the kind of a mind that enjoys complexity.
Mm-hmm.
So rather than being put off by it, my thought was always, gosh, that's interesting. I wonder what's causing that. And and so fairly early on in my career, I began to realize that other disciplines had answers that conventional medicine did not. For example, one of my first partners was a chiropractor, and I realized that he would be working with patients with neck and back problems, and he would get them well in a day or two with manipulation, and all I could offer them were painkillers and muscle relaxants, and it took them 10 days or longer to get better. And so I went up to him and said, well, would you teach me to do that? And reluctantly, he did. And I realized that touching people had phenomenal clinical benefits, including being able to be much more specific in fixing their problems. And and that launched me into many, many different areas. In medical school, I had studied hypnosis, and I realized that there were a number of problems that I could access by hypnotizing patients to help them get well that I would never have done in conventional medicine. And this led to a study of osteopathic manipulation, craniosacral work, homeopathy, acupuncture, and unfortunately, the list goes on. And this was constantly in the service of how can I help more people? How can I, if you will, put more tools in my tool bag to help more patients? And over the years, I got to working a lot with patients with chronic pain. I became the head of a chronic pain unit. And again, not only did I pick up new techniques, but back in the 1980s, when I was head of a pain clinic, we began to see an odd type of patient who had chronic fatigue and hurt all over, which we then called fibrositis. It's now called fibromyalgia. And back then, the common thought was, well, this has to be psychological. Nobody could have pain in all those areas for no obvious cause. And it became very clear after a while that these patients were not psychogenic. They did not respond to medications for anxiety or depression. They did not respond to psychotherapy. And so it was clear that this was a physical illness, even though most of the world looked at it, in fact, some people still do, as psychological. And then in the early 90s, we began to understand some of the causes. We began to realize that adrenal deficiency, thyroid deficiency, sex hormone deficiencies, magnesium deficiencies, intestinal dysbiosis, imbalance of the biome, food allergy, mold toxicity, Lyme disease, all were contributing factors. And for each patient, you had to look at each separately. So it was through that realization that looking at fibromyalgia and chronic fatigue was way more complicated than conventional medicine looked at it. In fact, back in those days, and to some extent still, conventional medicine looks at fibromyalgia and chronic fatigue as, well, we don't know how to treat that. And it's probably mostly in your head. And that's just wrong. So that's a long-winded explanation of how did a nice boy like me get into a field like this.
Well, it sounds like you're a true problem solver and a pioneer in this field. And I guess that, though, could lead to challenges from moving away from that mainstream conventional approach you mentioned and being at that doctor that dares to think beyond the common belief, the common dogma. How was that impact? Is that something you experienced, or was it a fairly accepted path that you took?
Oh, not in the slightest. I got into this field, as I said, actually in the early 70s, and by the late 70s, I thought that I had learned a great deal that conventional medicine would love. Keep in mind, I was new and naive, and so I took a position to teach at the University of Minnesota at one of the medical schools there. And I thought that medicine would embrace what I was learning with open arms because it was really very exciting. I was beginning to help people that my training would not have prepared me for. I was helping them with all kinds of techniques and modalities. And this was great, I thought. And I was stunned that it was met by not only skepticism, but at times ignorance, meaning I was hoping in a medical school setting that I would have dialogues with these folks like, well, okay, you might not accept it, but let's talk about the research that we're seeing. Let's talk about patient results. And what I was, again, stunned by or amazed by was, don't bother me with that information. I know what I know, and what you're talking about can't possibly be true. I did not know what to do with that, to be very honest with you. It was, wow. I thought that my profession wanted new information. And in truth, when you study the history of all science actually, but medical science particularly, it always, whatever the concept is met with hostility, which grows until the weight of evidence proves that it's true, and then medicine embraces it as if it discovered it first. And that's okay. But so eventually you go, well, all I know is that I am helping my patients. And to that, there's no question. So I don't have to question what I'm doing. I just have to keep doing what I'm doing. And to be honest, for all those young doctors who start going down this path, once you start down this path, you can't go back. You can't go back to denying the existence of Lyme or mold toxicity or chronic fatigue. You just can't do it. It isn't even a choice once you have gone down this road a certain way. There's no real other path that you can possibly take.
No, it sounds like it was such a closed mindset, and it sounds like exactly what you experienced, and it's...
Well, and as you know, it still is. There are whole countries that deny the existence of Lyme disease. And, to me, that's an astonishing concept. But what many people don't understand, and I unfortunately learned early, is that there are political agendas behind medical information. You would think as a consumer, well, something's either true or it's not, and you can either treat it or not. I mean, it's either a fact or it's not. And in point of fact, no, that's not necessarily true. That various regulatory agencies have agendas or have made statements, and they hate to be shown to have made those statements in ignorance or be wrong, and they will fight tooth and nail to deny the existence of something that they have publicly decried. And public doesn't know this. So public goes, well, all of these agencies are trying to protect me. If they tell me that there's nothing to it, then I guess there's nothing to it. And unfortunately, it doesn't work that way.
No, indeed. And it's just very sad that, a small subset of people's arrogance impacts such a large number of people in that way. And I mean, talking of Lyme disease, and it also leads on to how difficult it is to diagnose it. How do you go about that diagnosis? Do you have preferred tests, or do you use clinical diagnosis? What's your opinion on the CD57, for example?
Sure, that's a good question. First of all, it's difficult. The tests that we have are by and large not adequate to nail the diagnosis.
Uh-huh.
So the first thing is you need to look at the patient's symptoms, which is so varied, so exhaustive that actually the tip-off to diagnosis is when you see someone hugely complicated, then you begin to think Lyme diagnosis early on because they're so complicated.
Uh-huh.
So if someone comes to me who has muscle or joint pain or extreme fatigue or cognitive difficulty with brain fog, focus, memory, concentration, if they have anxiety or depression or unusual sensitivities, or they have numbness and tingling in different parts of their body, or nerve pain, these are so varied that the typical medical response is nobody could have all of those symptoms. Nothing that I know of causes it, so this must be in your head. But in my world, if you come in with those complaints, I know a whole bunch of things that could be causing that. Now we need to tease it apart. So the most important piece of Lyme disease is history, the complaints and symptoms that my patient presents with. Once I have that, now the testing becomes problematic. The gold standard in conventional medicine is what is called a Western blot test, where you simply get a blood test, and it measures what are called bands. Bands are simply pieces of protein on the Lyme bacteria that the immune system will make antibodies to. And there's all kinds of numbers associated with those bands. So by our CDC criteria, if 5 specific bands are positive for Lyme, that is defined as proof of Lyme disease. The other proof, by the way, is having had a bullseye rash. A bullseye rash is the definition of Lyme. So if an individual has a bullseye rash, which looks just like a bullseye, to be told by a doctor in an emergency room or a primary care doctor, oh, that's nothing, they are so wrong. That is, even in our country, that is the definition of Lyme disease, and it really needs to be treated. Mm-hmm. Okay. Having said that, the problem with the IGeneX, the Western blot testing is as it evolved, in our country, we developed a vaccine for Lyme disease against some of the most important of those bands. And the major tester companies took those bands out of the test because they were worried that someone who received the vaccine would test positive, and it would be a false positive because they'd been vaccinated. So our major laboratories don't test for some of the most common and important bands. Even though the vaccine was a total bust, it actually caused Lyme in up to 20% of the people who got the vaccine. It was taken off the market very, very quickly. But they never changed the test. So again, in the United States, we use IGeneX as our more accurate test because they test for all of the bands. Having said that, keep in mind, this is not a test for whether Lyme is present, but for whether or not the immune system has ever dealt with it or wrestled with it. So if the immune system has been weakened by Lyme, the test will be negative, even though the person has Lyme, because Lyme actually made the test negative. So a fairly high percentage of patients with Lyme will test negative and still have it. Second, it doesn't really tell us whether the Lyme is brand new, something the body is wrestling with, or old, because it's not capable of doing that. So although it is for many of us the best test available, it's still not a good test. There is a better test, and there's a little bit of new stuff that goes along with this. About 5 years ago, a laboratory called Advanced Laboratories figured out how to actually culture Lyme from the blood. So with a blood test, Lyme is a very, very slow-growing bacteria. It took 2 to 4 months, but if we grew Lyme out of the blood, that was way, way, way more accurate. It was thought to be 92% accurate as a test for Lyme, and I found it to be so. That laboratory has closed its doors about a month ago, but is going to reopen in another 6 months or so, and they're just retooling to do so. Mm-hmm. So when that test becomes available again, from my perspective, that is far and away the most accurate test. If you are growing the bacteria for Lyme out of the bloodstream, as far as I can tell, you have it. I don't see any other way that can happen. Now, in terms of the CD57 test, we thought early on in the Lyme treatment that that was a specific measurement of what the body was doing with Lyme, and we used it routinely. Unfortunately, we have discovered subsequently that it's a very inaccurate test in every possible way, and that many, many, many other things other than Lyme will lower the CD57 to give you a positive test, when in fact it may or may not be Lyme. By the way, one of the big things that is associated with a low CD57 is mold. So I actually don't use a CD57 anymore. It's way too inaccurate. It tells me almost nothing, certainly nothing specific for Lyme, and it's really not helpful in following the patient or making the diagnosis.
That's really useful, thank you. And you've mentioned, some of these complex patients might have multiple issues. So if someone does present with Lyme and co-infections and viruses and perhaps heavy metals or hormone imbalances or maybe mold toxicity, do you have a set of order that you'd deal with those in, or does that depend on the patient?
Well, number one, of course it depends on the patient. Mm-hmm. Now, some of those things need to be addressed early in treatment, and some of those things can be addressed later. The single most important concept to me is causation. Why is my patient sick? And that cause, whichever it is that I come up with, for me, has to explain the vast majority, if not all, of my patient's symptoms. And I want to emphasize that because as more and more physicians are getting into the Lyme world and doing the tests that we do, it is easy now to come up with a host of contributing factors to what makes the patient sick. And that will include positive viral titers to other bacteria like mycoplasma and chlamydia, like Lyme itself and co-infections and mold, heavy metal toxicity, as you mentioned, hormonal imbalances, as you mentioned. And so it's a super important question of what do you do first? And to me, the answer is you treat what's causing those things first. And I'm afraid that question doesn't get asked a lot. I see tons of patients who are addressing things like methylation and viral issues when those aren't the cause, they're downstream effects. And so what I mean by that is, let's say someone presents with the kind of constellation of symptoms that I mentioned earlier. Viruses don't cause that wide a degree of issues. Methylation does not at all. Heavy metal toxicity does not. Are those components of the illness? Yes, very likely. Are they the main thing that needs to be treated? No. So the single most important thing, and the reason I'm emphasizing it is I hope people don't lose sight of it, is you have to find the cause. And the cause has to fit the symptoms. Am I being clear?
Absolutely.
Okay. So when you come up with a treatment program, that treatment program needs to treat what is primarily this immune system wrestling with. And that's particularly true in the Lyme world, for example. Again, I see a lot of physicians, even ones that are Lyme literate, not taking the time to clarify what is the picture that I'm looking at. For example, if someone presents to me with intense sensitivities to light, sound, electromagnetics, food, chemicals, intense anxiety, inability to sleep, intense depression, balance, and muscle weakness, even if they have Lyme, which they might, those aren't primarily Lyme symptoms. Those are Bartonella symptoms. So I do see patients whose primary issues are those who are being treated for long periods of time with antibiotics that are specific for Lyme, but not Bartonella. And one of the fascinating things about our immune system is it seems to be incapable of treating anything but one infection at a time. So our immune systems define what it is what I call public enemy number one, by our symptoms. So based on symptoms, even if you clearly have a diagnosis of Lyme, the Lyme bacteria may not be what that immune system is fighting. It may be primarily fighting Bartonella. It may be primarily fighting Babesia or Ehrlichia or other things. And that is key to what we're approaching. So if you're going to treat Lyme, you have to treat the piece of Lyme that immune system is announcing by symptoms. And that would be true for mold toxicity as well, because mold toxicity looks very, very similar to Bartonella. Although one is an infection and one is a toxin, both stimulate the body to create inflammatory cytokines so that the clinical picture is very similar. So this can be difficult to tease apart, but key to all of this is really taking the time to clarify what are the symptoms that are bothering my patient the most, because that is the way the body is telling us this is what you ought to be working on as your primary objective.
Absolutely. And I think linking to that really is then how do you go about deciding the combination of treatment in terms of antibiotics, herb, energetic therapies, etc.? And equally, what advice would you give to our members if they're starting out on their journey and they're trying to make a decision about what approach suits them best?
Well, these are very difficult, and it's very difficult to pursue that. I do have a number of patients from the UK, and I know that the UK is not keen on the diagnosis of Lyme or co-infections, and that makes it very difficult for patients to obtain either the testing or the kinds of treatments that they really need. So my heart goes out to you because you're all in a very difficult position medically, where you can't get the care you need, probably unless you go elsewhere. I'm sorry that is the case. Hopefully that will change over time. But to come back to your very important question, how do you decide what to treat in what order? What I have discovered is if someone has mold and Lyme, you need to treat the mold first most of the time. And here's where individuality comes in. I would guess that 95 to 98% of the time, I need to treat mold first, then Lyme. Most of my patients, and I'd like your listeners to know that I don't have a typical practice of anything. In fact, even for a Lyme literate doctor, my practice is even more atypical because I have referred to me the patients that my colleagues didn't know what to do with. So I treat an unusually sensitive and toxic group of people that require a slightly different approach. So in my patients, you can only treat one thing at a time. In patients who are stronger constitutionally, you might be able to treat several things at one time. So in a stronger patient, you could treat mold and, say, Bartonella simultaneously. But in my patients, that's impossible. They're way too sensitive, way too reactive to everything you give them. You have to start with small, tiny doses and then work up from that. So in my patients, mold comes first. One of the reasons for that is I think of the clinical picture as peeling away the layers of an onion. And so what I'm looking at is the symptoms that my patient has. If I treat the mold, many of those symptoms will simply disappear completely, changing the clinical picture. So I want to peel off the outer layer first before I get involved in the potential use of long-term antibiotics later. Meaning, I've already mentioned that mold and Bartonella look very similar. Well, the mold tests are much more accurate and definitive than Lyme tests, and much more definitive than Bartonella tests, which are way worse. And way worse in terms of accuracy. So my patient may not actually have Bartonella, even though it looks like it. They may just have mold. So if I take the mold piece away, I might be looking at a completely different picture underneath that. So my first effort is on treating mold. And that is usually rewarded by significant improvement and clarification of the clinical picture. I often find that many Lyme patients who have not succeeded in their treatment have mold and Lyme, and part of the problem is they haven't looked at mold or treated it because the inflammation that mold produces is preventing that body from getting at the mold or the Lyme or co-infections that are also present. So generally you start with mold. If Lyme or co-infections are underneath that, I treat them sequentially in the order that the symptoms present. And at that point, the immune system has usually recovered pretty extensively. So if there are viral pieces, the immune system now can contain it. The essence of Lyme or mold is a weakening of the immune system. Once the immune system has recovered, it will control the viral piece, and it does not need treatment. It will control the chlamydia or the mycoplasma. It does not need treatment. So I find that going after those infections as a primary event rarely leads to improvement because you're not working on the piece that body wants you to work on. You need to be in sync with what that immune system is telling you is public enemy number one.
Thank you. You mentioned during that that mold testing is a lot more sensitive than Lyme testing. What tests do you recommend for mold toxicity? Because it sounds like it's a big part of your approach is to either establish that mold is an issue and treat first, or discount it, and therefore, depending on the symptom picture, perhaps it's Bartonella or Lyme or whatever causing the worst symptoms.
Well, we now have much more definitive testing for mold, and there are 2 laboratories that do it. Until recently, there was only one really that did it, and that was the real-time laboratory in Houston, Texas, where you would submit a urine specimen to the laboratory, and they would test it not for the molds themselves, but for the toxins that mold make that make us sick. Mm-hmm. And you can literally quantitate the amount of toxins present. So a positive test on a urine mycotoxin test is a very, very clear indication that that person has mold, or more correctly, has mold toxicity. More recently, there's a laboratory, again in the States, called the Great Plains Laboratory, which has a mycotoxin test, which I suspect is going to pan out as more accurate and more reproducible because the technology behind it is better.
Mm-hmm.
And although it's only been available for a few months, I've probably run 40 or 50 specimens past that laboratory, and I find them to be very accurate and very reproducible. And the combination of laboratories at this point gives us a very complete look at mold toxin. And not only does it tell us the diagnosis, which is, yes, you have mold toxicity, and this is very clear, but how to treat it, because I'm assuming we'll later get into that. But the specific toxins that you have informs us as a blueprint for how to treat it.
Right, I see. And obviously, mold toxicity is one of your areas of expertise, but I'm aware that there's a few different approaches to treatment. You've just mentioned it there, and I'm aware of kind of Dr. Joseph Brewer and Dr. Shoemaker, and how those approaches differ quite a lot. And could you explain to us sort of the main differences and what your approach involves, please?
Certainly, and it can be very confusing to patients.
Yeah.
I worked with Dr. Shoemaker early on. We taught together, lectured together, and over time, we kind of developed a different understanding, which are significant. So I'll talk for a moment about the Shoemaker model. And first of all, I want to give Dr. Shoemaker credit for having put mold toxicity on the map. His initial books and work were pioneering, genius. It really brought to us the understanding of how common and how profound mold toxicity is and how to understand it. Mm-hmm. So Dr. Shoemaker put together something that he called the biotoxin pathway, which is a brilliant understanding of exactly how mold toxin makes us sick, how it affects all the different systems of the body, which are so confusing to other physicians who say, well, you can't have all of those things go wrong at the same time. And mold toxin does all those things. It specifically affects the pituitary gland so that our hormones are completely out of whack, particularly adrenal, thyroid, and sex hormones are commonly difficult to regulate with mold toxicity. It affects the immune system. It affects our weight by how it affects leptin chemistry. It affects brain inflammation. It affects how parts of the brain are infected, which creates chronic fatigue, cognitive difficulties, difficulties with mood swings, anxiety, depression, very odd neurological symptoms, odd things that look like seizures that we call pseudoseizures, dyskinesia, which are tics, twitching, spasmodic motions that neurologists can't quite figure out. So all of those things are things that mold can do, and Dr. Shoemaker showed us how that happens. So it took the mystery out of, is it possible that patients can actually have all this stuff? And the answer is, number one, they do. Second, we even have a logical way to understand all of that. Mm-hmm. He then got figured out a few basic ways to treat this, and primarily that included using a binder, which is available by prescription, called cholestyramine. And the primary concepts that Dr. Shoemaker utilized to treat mold, which worked for many patients, were number one, we have to analyze the home that that person lives in. If the home is moldy, or the workspace, or the car, then the person will never get well until you get into a safe environment. And while that is kind of obvious, it's very difficult for people to do for all kinds of social and financial reasons. It's not as easy to move as it is to say, you live in a toxic space, get out of there.
Mm-hmm.
And as I know, I have quite a few patients in the UK. Many of them have discovered they live in a moldy environment, but finding a safer apartment or place to live has proved very difficult. In London, for example, which is, old, long, damp buildings have had centuries to acquire all kinds of mold species. So it's very difficult for many patients to find a safe place. And that is one of the harder aspects of treatment. But having said that, getting to a safe place, treating the toxins with cholestyramine, and then he has an elaborate group of oddly named biochemical markers that are, for those of your listeners who are aware of it, they include things like MMP9, C4A, TGF-beta1, VEGF, and so on, that he has an elaborate system of how to treat those when those numbers are abnormal, that he teaches to people in his courses. So the question is, how does what I do differ from that? Is, number one, Dr. Shoemaker, for a variety of reasons, does not accept or believe in the accuracy or use of the mold tests. So to me, that creates great difficulty because his tests will miss the diagnosis in a large number of patients who have mold, who clearly are overloaded with mold toxin in their urine. Number two, he also doesn't believe, as I do and many other doctors do, that once patients have been exposed to mold for a period of time, the mold actually starts to colonize or grow, particularly in their sinus or gut areas, so that even if they move to a safe environment, they're still making it internally. And so a whole piece of mold treatment involves using antifungal medication to eradicate the mold from the sinus and GI tract. And that is, again, something that Dr. Shoemaker does not agree with or work with. The third major area of disagreement is that because I am working with the toxins, we know a lot about which binders bind which toxins. And Dr. Shoemaker uses cholestyramine almost exclusively as the only binder he uses. Now, if you had ochratoxin, for example, that's great. It's a superb binder for ochratoxin. It is not a good binder for trichothecene or aflatoxin or gliotoxin and so on. So by knowing which toxins, one area of disagreement is I believe that you can specifically give the binders to a patient that are going to work for the toxins they actually have. And so a lot of the work that I do was developed by Dr. Joseph Brewer, who is an infectious disease specialist from Kansas City, who discovered back in 2013 that he did a published study in which he took 112 patients with chronic fatigue syndrome who were not getting better from any treatments, and he measured the mycotoxins in their urine. And lo and behold, 92% of those patients had mold toxicity. And when he treated them, 94% got better. So this is a profound piece of information. It tells us that mold toxicity is more common. And one of the key things that Dr. Brewer discovered, as I'm referring to, is that when he looked at the environment of many of those patients, they were completely mold-free. They scrutinized their home, work, car, no mold there at all. But all of those patients, when questioned, said, well, yes, but I lived in a moldy house 3 years ago, 5 years ago, 10 years ago, 15 years ago. So it became obvious that these patients had colonized and that had to be included in treatment, which is what Dr. Brewer discovered. And that's the model that I basically work with, meaning I think that Dr. Brewer's work has taken Dr. Shoemaker's work and moved it forward, if you will, in quantum jumps, so we can do a much better job than we could before.
It absolutely sounds that way. And going on from that, and I understand the need to treat someone even if you remove them from the mould environment, but I guess it's still an important part to remove somebody from that mould environment as part of treatment. Is that correct?
Yeah. Can you restate that, please?
So, Dr. Brewer says that even if someone has been removed from their mould environment, they're still creating mould in their own bodies.
Yes, exactly. And that's a very important thing for patients to understand, because they may say, gosh, in my house, I don't smell mold, I don't see it. But if they reflect, they may recognize that when they were at university, they were in a moldy dormitory for several years, etc. So many of my patients initially do not want to consider that, and at my first visit, when I ask them about mold, they vehemently deny any exposure, and the vast majority on their next visit go, I was thinking about that, and I lived in a moldy environment here and here and here and here, and then we have more to talk about.
But in those examples, if they were still in a mould environment, Dr. Brewer and your approach would be to, where possible, remove them from that environment.
Right. One of the things that we all agree on is you can't get well in a moldy environment.
Yeah. And is it really necessary when you move away from that environment to throw everything away? Some of the approaches seem really quite drastic. Is there anything that can be done that's less drastic?
Well, I think that that's an overstatement generally. There are certain objects that tend to retain mold or mold spores or mold toxins, and some don't. For example, clothing and bedding and things like that can be washed. And normal laundering or washing will wash mold toxin and mold spores out. So you don't have to throw away everything you own. Many surfaces of objects that you own can be wiped down, although I recommend that whoever is doing the cleaning not be the person with mold toxicity. That's a very bad idea. But they can be wiped down and cleaned. Most metal surfaces, some wood surfaces, depending on how the wood is sealed, can be cleaned off, wiped off carefully with soap and water, and sometimes with Clorox or other ingredients, depending on whether those are compatible with it, and be saved. The hardest thing is typically photographs, papers, many things that are very precious to patients. Those are very, very difficult to clean. And it is possible to do so. And so if you're going to move and you have things that you treasure, have someone else box them up in sealable plastic boxes and put them away for a while, and then figure out later whether any of that can be retained. But I've had quite a few patients get very frustrated and finally get rid of everything they own. That does work, but it's also very emotionally difficult. Many of those things are heirlooms that have passed down the family, and one really hesitates to go, do I really have to get rid of that?
Well, that sounds like a much less drastic approach that you're explaining there. So I think a lot of people will be comforted by that. For people who are suffering with symptoms of mould toxicity and have no known mould exposure, but who can't access private treatment at present, is there anything that you can recommend that they can do at home to reduce their toxic load, over-the-counter remedies or similar?
Well, there are. So first of all, those people want to have a good HEPA filter, which will remove some of the mold spores from the air. And a home can be cleaned to minimize mold exposure. One of the people I work with is a wonderful mold evaluator named John Banta, and he has written a 10-page blog. If listeners are interested, if they go to my website, which is www.neilnathanmd.com, and look at the blog section, there's a wonderful 10-page paper by John Banta on how to clean your home to minimize any mold exposure.
That's brilliant. Thank you. That's really great to hear. I guess leading on to that, things at home for not just for mold, for very sick people. What would you recommend in terms of simple dietary and lifestyle changes people can make to strengthen their immune system or manage their symptoms?
Well, as a general rule, I'm going to step back from that for a moment. First of all, the ideal diet for human beings varies enormously with the biochemistry and genetics of every individual. So first of all, there is no one right diet for anybody. Some people need to be vegans, some people need to be carnivores. And what I encourage all patients to do is to experiment with their diet to see what their body likes best. That's key. Also, many people are completely unaware that they have developed food allergies, meaning some of the most common foods people eat, like wheat, dairy, corn, sugar, citrus, pork, the nightshade family, which are potatoes, tomatoes, eggplant, and bell peppers. Those are some of the commonest foods that will trigger a wide variety of food reactions. And it behooves everyone who is sick to at least go off of all of those foods for at least a week to 10 days to see if they feel better. If they do, they should reintroduce those foods one at a time to discover whether there are foods they can't eat. It's extremely common in Lyme and mold patients to become sensitive to gluten, for example. It is the rule rather than the exception, but not everyone. So to tell everyone that you cannot have gluten just doesn't work for some patients. It's too restrictive a diet. So each person has to discover for themselves first what their body likes and what they don't like. Second, within that context, mold and Lyme do best on a high-protein, low-carb diet. Sugar, including fruit, is generally not good for that immune system, and then we can discuss all kinds of variations of a high-protein, low-carb diet, including Atkins, ketogenic diets, paleo diets, GAPS diets. All of them may work better for one person than another, and I encourage patients to experiment to find out for themselves what works best.
Thank you. That's really helpful. And if someone has discovered they've got severe food intolerances, is there anything they can do over time to boost their immune system or reduce their responsivity, I suppose, more, in order to expand their diet, to reintroduce some of those foods?
Yes, later. Once you know what you can't eat now, it's really important to stay with that for now. You may be able to increase those foods later. If someone has a true food allergy, that may not happen. Children can outgrow food allergies much more readily than adults can, but I often see that once someone is very sensitive to a particular food, they will not outgrow it. On the other hand, there's another type of food sensitivity which is triggered by mold or Bartonella, typically, and that is another example of the type of hypersensitivity or reactivity that mold toxin and Bartonella creates. Now, that may present as what we call multiple chemical sensitivities or food sensitivities or mast cell activation, but those can improve dramatically with treatment so that over time, those reactivities you can fix and cure with the right treatment.
Mm-hmm. Mm-hmm. And we've
Am I
talked
being clear?
absolutely, absolutely. We've talked quite a lot about sensitive people, and I think a lot of your clients are very sensitive. One question that came in from a member is if somebody is so sensitive that they seem to react to any herbal medication or pharmaceutical medication, and they get kind of mast cell responses and autoimmune type responses. In your opinion, would you say that homeopathy would be enough to get someone well, or at least enough to reduce the sensitivity of that person?
Well, first of all, patients who are that sensitive react to homeopathics the same way, meaning minuscule doses of homeopathic remedies are often not tolerated by very sensitive patients.
Mm-hmm.
So um, you may be able to discover some homeopathic remedies that individual can take, but homeopathics are just sensitizing as any of the other things you've mentioned, like pharmaceuticals or herbs. In fact, really sensitive patients are remarkably sensitive to homeopathics. And this astonishes those who practice those fields. You can go, well, this is such a dilute remedy already. How could you react to that? And the answer is they do. And they react very intensely to minuscule doses. So the answer to your question is generally that is not the way out. Generally, that will not provide the kind of help that those folks need.
Okay, thank you. Conscious of time, but I think one thing that would be interesting to touch on before we move to some of the questions about what you're doing at the moment is two parts that I think are slightly interlinked. What are your thoughts on the limbic system impairment playing a role in illness and illnesses like Lyme disease, and on programs such as Annie Hopper's DNRS?
Mm-hmm. Right. Well, I think that's a wonderful segue from my last answer, which is the number one best treatment that I have seen for those patients who have gotten so sensitive that they can take almost nothing. And there's a couple of answers to that. The best is the Annie Hopper DNRS or limbic retraining. Mm-hmm. That limbic hypersensitivity is a huge part of all of those patients. And I know that Ashok Gupta also has a program that a few of my patients have used. But the one I'm most familiar with is the Annie Hopper program. I've had well over 100 of my sensitive patients use it. And it is the number one, nothing comes close way of quieting down a reactive system so that patients can start to do more. So I am a huge fan of that process. I've seen it do just remarkable things for patients who were so sensitive that they were down to eating 3 foods and were just at their wits' end because there was almost nothing that they could do. Within 4 to 6 weeks of doing that retraining program, they had already increased that. They were able to start the more specific treatments of things we needed to do. And let me add that when you have someone that sensitive, almost always we're looking at mold or Bartonella. And I would roughly estimate 80% of people who are that sensitive are mold toxic. An additional 20% have Bartonella, and many have both. So once you get sensitive, that is diagnostic of mold and Bartonella, and those ought to be things that practitioners look at first when you have someone who's become that reactive.
Mm-hmm, mm-hmm. And as you said before, if you're treating with Lyme-specific treatment, then that person may well not get better, may not respond. So it's important, I guess, to have those.
Yeah, that's exactly correct. If you're treating Lyme itself, Borrelia, and someone is that sensitive, you're probably not treating what that person needs you to treat. Mm-hmm. You're on the wrong wavelength.
Mm-hmm.
It's not that it's not that that person doesn't have it. It's that that's not what that immune system wants you to treat first. You're just working at cross purposes,
Mm-hmm.
and that's not merely not helpful. That means that that body has to detoxify those antibiotics, those herbs, and it sort of has to, forgive my term, squander the liver's work and resources when they would be much better used in a much more direct treating fashion, getting at what's really causing it.
No, that absolutely makes sense. Um, Again, something a bit separate from treating infections and mold toxicity, but how important have you found it for your patients to address any emotional and spiritual aspects of healing?
Huge. Um, um, Nor can you separate it from the physical,
Mm-hmm.
meaning it's impossible to be as sick as my patients are and not have some degree of anxiety or depression. Now, when that anxiety and depression is out of proportion or very intense, then we're looking at a physical cause for that, which is primarily, again, mold and Bartonella. However, it's still not possible to be as sick as my patients are, as limited. These are people who have led productive, valuable lives who all of a sudden cannot do anything. They're requiring caretakers. They're limited. They're um, sometimes unable to get out of bed. Um, and and those folks, you can't even imagine them not having an emotional or spiritual component. One of the spiritually, when you are not able to do what gives your life meaning and purpose, and meaning and purpose is devolved into trying to get up in the morning and get through your day and then get through the day, and there's nothing but misery, suffering, and pain in the middle. This is not easy to find spiritual meaning in that kind of a life, but it's imperative that patients do. Meaning, if you devote your whole life to the invalid role of feeling sick, there's no way you'll get well if you don't go back to finding some meaning and purpose in your life and doing, even with what limited energy you have, doing something that helps you to feel good about what you're doing and contributing to the world, being of service in some way. That's critical.
Thank you.
At the end of treatment, once we've gotten a lot of the physical components fixed, I often find that those patients who do not then work on the emotional and spiritual components of their lives that may have in some way predisposed to illness, some of them will not get well until they do so. Meaning, illness, as horrible as it is a fabulous opportunity to relook at your life, the direction of your life, what you're doing with it, what gives your life meaning and purpose. And for many patients, part of the illness role or job is to wake you up to, are you living the kind of life you really came here for? Like, what are you doing with your life? Mm-hmm. So many of my patients who have been high-powered executives, high-functioning individuals, doctors, attorneys, engineers, you name it, if the only way they look at their illness, which is, I want you to get me back so I can work as hard and as stressed out as I used to, those people may not get well. They need to look at their lives and go, what can I do differently? How can I reframe? I can still be very productive and useful and valuable and earn whatever income I need, but maybe I don't need to do it the way I did before. Maybe I can add more humanizing components to it. Maybe I can spend more time with my family, my friends, my community. Like how, and I find that patients who do not look at those pieces, often their illness will linger.
Yeah, I can relate to that, definitely. I guess something that's really important, given we've been speaking for all this time and people are going, to be listening to this from Lyme Disease UK. How do people become a patient of yours? Do they need to come and visit you in person, or do you offer Skype consultations? How do you approach seeing patients?
Oh boy, that's a hard question. Harder than you might think. First of all, I'm taking very few new patients. And part of that is that I've changed my work schedule a bit in the last 2 years, so that how can I put this? I'm working 2 full days in my office, but I'm doing 2 or 3 days of basically phone consultations. Mm-hmm. And because there's only one of me, and I seem to be in some demand, there's no possible way I can treat all the people who want me to treat them. Mm-hmm. And so what I'm really trying to do is teach other people to do what I do. So I am available for phone consultations. If you go to my website, it's outlined what you can do to set those up. And what I prefer to do is to do a conference call with my patient and their healthcare provider, so that I can outline for the healthcare provider what to do. I can't treat patients by California law, which is my license. I can't treat patients over the phone. So I can't legally diagnose, and I certainly can't prescribe any medications or anything for someone who has not actually seen me in my office face-to-face. So to help as many people as possible, I try to provide direction to them, and my preference is to give direction to the patient with their healthcare provider involved, so that that person can provide the care and I can simply provide direction. That's mm-hmm. my current preference. That's what I've been doing for the last 2 years, and it's worked out very well. I've been able to help a whole lot more people and teach other doctors how to do this, hopefully better. And I'm really happy with how that's evolving. So I'm sorry that I can't be everybody's doctor.
Like you say, there's only one of you, and on top of everything that all of these people you've treated, you've also written, numerous books, presented at conferences, had your own radio show. What does the future hold for you? Have you got any exciting projects in the pipeline at the moment?
I do. I'm just finishing up my next book.
What brilliant!
Which you will not be surprised. The current working title is called Really, Really Sensitive and Toxic People and How to Help Them Get Better. Mm-hmm. And I just have, looks like it is possible that I have a publisher for that, and the hope is that might be able to be out by fall of this year.
Wow, that would be brilliant.
Right. So I'm just close to finishing writing that, and I'm very, very excited by it, because I don't think there's anything like it, and I hope it will provide some direction and guidance for all of those literally millions of people out there who have become really sensitive and toxic, and whose healthcare providers don't know quite what to do for them. Mm-hmm. And let me add to that this is the tip of the iceberg. My underlying observation is that this sensitivity has increased astronomically in the last few years. I mean, keeping in mind that Lyme disease has exploded, at least in our country. Our CDC admits that there are 300,000 new cases of Lyme every year. So we're out of the denial phase that it exists. Not doing anything about it, we're not giving any research money to it, but at least we're moving out of denial. Mold toxicity is even less appreciated and really not given much attention. But these are epidemic. We're talking millions of people in our country and millions of people worldwide who have these illnesses, who don't even have a diagnosis, who are being told by their doctors, this is in your head. But the cause of this is worldwide toxicity. And we're talking about toxicity of chemicals, heavy metals, electromagnetic exposures that it's critical that people understand that we are all going to be sick before long if we don't do something about it. It is these exposures that is literally making all of these things that we're talking about epidemic. And it's going to get worse quickly if we don't, as a universe, open our eyes to what we've been doing and really begin to clean up our environment. And I don't think we have much time to do that.
No, we're literally creating the perfect breeding ground, aren't we, for these infections and toxicities.
Okay. So get back to just what I'm doing. My book will be out fairly soon for listeners who want more. I did write an ebook about a year and a half ago, which is simply called Mould and Mycotoxins. It's available on Amazon. It's about 40 pages. It's quite readable, which will hopefully allow them to really understand what I'm talking about and how to pursue that. And I'm doing a ton of teaching now. In the next 3 months, I have 3 major medical meetings that I'm going to be lecturing at, again in the fall. So I'm trying to share what I know with as many physicians as want to come and listen. And I'm hoping that patients can get better care once their doctors have a better understanding of the bigger picture here.
Mm-hmm, absolutely. No, thank you. We'll include links to those and your website when we put this onto the Lyme Disease UK website. Really conscious of time, but there is one question that we always like to finish with when we do these interviews, and it's, what advice would you give to a member of ours who feels there's no way out?
What advice would I give to
someone who feels that there's no way out? They're so sick and they feel there's no way out.
Well, first of all, there is a way out. So everything I'm talking about now can be treated.
Mm.
The key is you may have to put out more time and energy than you hoped to find someone who knows what they're doing and that they can treat you properly. There are not a lot of people who are knowledgeable, but many people have pieces of it that can at least get started working with. But my absolute message is, although the things we're talking about are nasty, every single one of them can be treated. The majority of people that I treat get well. So I don't view this as, oh, how awful, you have Lyme or Mold. Sorry about that. I look at it as, you have a treatable illness. Let's get going.
Yeah.
And that's key. There is hope. There is massive amounts of hope. Even though an individual might feel like they've not gotten anywhere, my only comment will be, well, look harder. Find someone who can help you here.
Brilliant. Thank you so much. Thank you so much for your time today. We really, really appreciate having you here and all of the advice and knowledge you've given to us. Is there anything else you wanted to add before we close today?
Not really. I appreciate you having me here and on your show, so that I hope that this information will be helpful and valuable to your listeners, and maybe allow them to understand not only what they have, but maybe where they want to turn to get the kind of help that they need.
Absolutely. I'm sure it will. Thank you so much for your time. It's been a pleasure to talk to you.
Okay. Same here. Have a wonderful evening, and take care.
Thank you. Bye-bye.
Okay. Bye-bye.